Okay,
I still have the slides.
great.
Are you gonna walk around? Are you okay with that there?
Okay with that there.
You're there, and then you can use the little up there.
Yeah, okay, perfect. And it's the new slides. Okay, so this advances. Wonderful. All right, so it's my pleasure to talk a little bit about genetics and hopefully demystify it a little bit as well. Don't worry if some of it doesn't make sense. I'm going to have take-home points. Take as much away from it as you want, but it's okay if not all of it makes sense. I have no disclosures. So I'll start out just by giving a little genetics 101, some of the basics, and then talk about why genetic testing and molecular testing is so important, types of testing that can be helpful. I'm going to focus this talk on ovarian cancer. I wanted to cover endometrial cancer also, but there just isn't enough time in the time period I had. Some of these principles also apply to other cancer types too. And so I think genetics really got a lot more prominent when Angelina Jolie came forward saying that she had a BRCA1 mutation that predisposed her to a significant up to 80% lifetime risk of breast cancer and a 50% lifetime risk of ovarian cancer. And she chose to have her breasts removed and to have her ovaries and fallopian tubes removed to prevent these cancers from happening. And so that raised really important public awareness about the importance of genetic testing and the power of genetic testing and options to prevent cancer for mutation carriers. And so people will ask me, well, what if I already have cancer, unfortunately? Why is genetic testing, why does it matter still? So it can certainly help family members, and we'll talk a little bit more about that. For you yourself, if you have a mutation, it can identify risk of other cancer types that may influence screening or prevention options. And then it actually can influence prognosis and treatment options for the cancer that you have as well. So a little bit about genetics 101. So first, what is a protein? So a protein is a complex molecule that does most of the work in our cells. So we have, tons and tons of protein all in our body, and they do all these important jobs. Each protein has a specific job. And so this is just one complex pathway of proteins that all interact to repair. We all get DNA damage as we go through our lives from sun, from other things, just natural errors. And our body fixes a lot of those and has a lot of pathways to fix those. But when you get one of those proteins that doesn't work anymore, then that process goes awry. So a gene is a portion of your DNA that makes a specific protein. So the BRCA1 gene makes the BRCA1 protein that is important for that pathway I showed you. A mutation is a change in the sequence of your DNA that then makes the protein not work when that the protein can't be made. And so why do inherited mutations increase the risk of ovarian cancer? Most ovarian cancer risk genes are involved in DNA repair. When DNA repair is not effective, cells can accumulate mutations that then can lead to cancer. The cells start growing uncontrollably in a way that they weren't supposed to. So how do we inherit our genes? So we each have 2 copies of each gene. One we got from mom, one we got from dad. So you can see here, mom, and I did different colors just to represent that each gene might be slightly different in the sequence of DNA. So the child, let's say, got the dark green copy from dad and the dark blue copy from mom. You could also have that they got the light blue copy from mom. And so there are actually 4 different combinations that they could have. So how do you inherit a mutation? So let's say mom has a mutation. Remember, you can get either copy from mom. So then that means you have a 50% chance of inheriting that mutated gene. And it only takes 1 copy to have that risk of ovarian and breast cancer that I was showing you. So inherited genetic mutations, these are present in every cell of your body. We start out as 1 cell when we grow as an embryo, and then you have this in every cell of your body. And so these inherited mutations are also called germline mutations. That's going to be important later because there are lots of different types of genetic testing, and germline testing, where you look for inherited mutations, is one of them. So some other things just to keep in mind, not everyone with a mutation will actually get cancer. So remember, Angelina Jolie had up to a 50% risk of getting ovarian cancer with her mutation. That meant 50% of the time, you know, like people might not get ovarian cancer. And that's likely because of a complex blend of other inherited factors and environmental exposures. We don't always know why someone does, and you know, unfortunately, and then someone doesn't. Also, I'll just share, because this is a little bit of a myth, you can't skip generations. So like if your grandma had a BRCA1 mutation and she didn't pass it down to your mom, you can't get it from your mom, right? Your mom doesn't have the copy. So if that didn't get passed down, and so what causes hereditary or inherited ovarian cancer? Mutations in certain genes, such as BRCA1 and BRCA2, which are really the most famous, I think in part because of Angelina Jolie, and also because they're the most common ones. But we've learned over the years, ever since genetic testing started getting done, that there are actually a lot of other genes that are important as well. So there are Lynch syndrome genes. I crossed out PMS2 here because that is a Lynch syndrome gene, but that is one of the few that doesn't cause ovarian cancer. And then other genes kind of in the DNA repair pathway. And you don't need to remember all of these, but it's just to kind of drive home the point that if you only had BRCA1 and 2 testing, you might be missing something. And so patients with ovarian cancer have a high rate of inherited mutations. Nearly 20% of ovarian cancer is actually inherited. 15% in genes that are BRCA1 and 2, but 4% in other genes. And you might say, well, 4% doesn't sound like that much, you know, so, well, if I had BRCA1 and 2 testing, that's probably good enough. But, you know, when you look at all of the people who have mutations, these other less common genes make up a considerable portion of the pie. So we don't want to miss these. And so recommendations for genetic testing is that all individuals with ovarian cancer should have genetic testing. 1/3 of people with mutations don't have a family history. Like you think, oh, well, I have a bunch of family members with breast and ovarian cancer, I'm at risk, but 1/3, they were the first one in their family to develop cancer. So you, again, like anyone with ovarian cancer should be tested. And similarly, it's not always just people who are young that had a mutation that caused their cancer. 1/3 of people over 60, average age of ovarian cancer is in the early 60s, are over 60 at diagnosis. So this is why we have a policy and a recommendation that every individual with ovarian cancer, regardless of age or family history, should get this testing. And so remember, this is when it's inherited, that means it's in every cell of your body. So you can test for this either with a cheek swab and test the cheek cells to look for the mutation, or a blood test, or some common ways that it's done. This is maybe becoming a little bit more of historical interest, but you know, there are different ways to do, quote, genetic testing, even for inherited mutations. You can look for one specific mutation, like the one that got passed down from, you know, grandmother to dad to you, a very specific mutation. There are founder mutations that Ashkenazi Jewish population have a higher rate of that you can test for. You can test for just single genes, like just test sequencing the whole BRCA1 and 2. Or now, and this is really the most common, is you can do a panel that includes all of the known ovarian cancer susceptibility genes. And I think, you know, that is what we would all advocate for at this point in time, is for most people, is to get a whole panel so that you're not missing any of those other genes. So that's take home point number 1. All patients with ovarian cancer should have germline genetic testing, ideally in a panel. So now I'm going to take some time to talk about why genetic testing is important. I'm going to start with the second point, which is that even if you have already had an ovarian cancer, if you have one of these genes, it may influence your risk for other cancer types, which can change recommendations for screening or prevention. So several of these genes also increase the risk of breast cancer, and you can do enhanced screening with mammogram and breast MRI. And for some genes, people sometimes consider a risk-reducing mastectomy, where they actually remove the breast to prevent the cancer from ever happening. If someone has a Lynch syndrome, that increases the risk of colon and GI cancers, uterine cancers, and other. And there's increased screening with colonoscopy, upper endoscopy, other things. It can also help your family members. So, you know, I shared that up to 20% of ovarian cancer is hereditary, and if we were able to identify it ahead of time, can theoretically be prevented. And so I shared with you that there's up to a 50% risk of developing ovarian cancer with the BRCA1 mutation, and there's up to a 20% risk of developing it with the BRCA2 mutation. And knowledge is power. There are a lot of things you can actually do to prevent those cancer, including birth control pills, surgeries to remove either the fallopian tubes or both the fallopian tubes and the ovaries, and that's very effective. So that is a way that it would be really beneficial to know. And I'm going to share kind of with your family specifically how this can help. So this arrow, let's say, is you have the BRCA1 mutation. Your mom also had it, and she also unfortunately had an ovarian cancer. And that means each of these people has a 50% chance of having inherited the mutation. So each of these people, so, you know, the patient's, all of her sisters or their sisters, and then children should be tested to see if they inherited that. And so they can actually look at that specific mutation and then test everyone for it. And so let's think about, you know, a theoretical patient named Meryl who has 2 daughters. Her first daughter, Stephanie, has the BRCA1 mutation. And so now they know she also has an increased risk, and she has many ways that she could choose to reduce her risk through surgery, birth control pills, other things. In contrast, Alice tested negative. And let's say Alice actually had gone through her whole life with this family history of so many people in her family of having, you know, cancer. She assumed she was at an increased risk. And she's now learned actually she's not at an increased risk and doesn't need to do any of those things. So that can be really powerful. So the last thing I'll talk about is another reason genetic testing can be helpful is that it influences prognosis and treatment options for someone who has been affected by cancer. So we know that if you have certain mutations in BRCA genes and also some other genes in a similar pathway, that actually has an improved prognosis. Now, as an aside, I always ask people to take statistics with a grain of salt, because certainly we have many patients who don't have these mutations who still can do, you know, very well. And for you, it's all or none, right? So, you know, just kind of wanted to call that out. But certainly that's something sometimes people want to know. And then genetic testing can influence guidance of maintenance therapy and also possible identification of novel therapeutics. So remember I talked about germline testing, which means that that mutation is in all of the cells in your body. Now I have to introduce a second concept, which is equally important, which is tumor testing, or also called somatic testing. So this is, again, someone that did not inherit a mutation, but their cancer arose spontaneously and spontaneously developed a mutation in that tumor. And so you can biopsy the tumor and find the mutation there, but they wouldn't have that mutation in all of the cells in their body. And it turns out that also can influence how the cancer behaves to different therapeutic options. That, you know, shows that that was influencing how the cancer behaved. And so both of those are important. So I'll talk a little bit about maintenance therapy. So maintenance therapy is a treatment that is given after chemotherapy. It's given to continue or maintain the good results of a prior treatment. And the goal is to decrease the risk of the cancer returning, or if the cancer were to return, to delay the time before it returns or worsens. So there's a lot of things you should know about maintenance therapy. How will you feel? There still can be side effects, even with maintenance therapies. What is the potential benefit? Usually you have to still have office visits and blood work, things that remind you of your cancer diagnosis. And so it's a conversation about risks and benefits between you and your provider about if this is something that you want to go on or not. And you should think about kind of what your priorities are. So time off chemo, or is being symptom-free really important? Being able to travel or work? And will being on the maintenance therapy help you to achieve your most important priorities? So I'm going to talk about, people talk about maintenance therapy and benefit, and I just want to frame it what we mean by that, because I think it means different things for different people. So pretend we had a crystal ball, which of course we don't. And that if we could know that someone finished their chemo, and if they stopped their chemo, that the cancer were going to come back in a year. But that if they took a maintenance drug, we'll call it drug A, that the cancer wouldn't actually come back until 3 years. well, then we would say that that it delayed recurrence by 2 extra years. That was 2 more years that they didn't have to go back on other treatments or address it. And then that is, quote, a 2-year benefit. So I'm going to talk about that when we think about benefit with maintenance. And so let's say we have maintenance drug A with a 2-year benefit. Let's say that drug only causes mild side effects. You generally feel well. Would you consider that worth it? Most people would say, yeah, most people would say that's worth it. What if you had severe side effects? You felt terrible. You can't enjoy life at all. You feel worse even than you were on chemo. Would that still be worth it? Maybe, maybe not for some people. But then there are other drugs where the benefit might be less. Maybe instead of 2 years, it's only 3 months. And then no side effects at all? Probably worth it if you feel exactly the same. What if you have moderate side effects? Is that worth it? And I would argue that different people would make different decisions, knowing that there's a different level of benefit. And that's where sometimes the genetic testing, if you want that information about a potential for benefit, could help you make some decisions. So we have, standard treatment for newly diagnosed ovarian cancer is carboplatin and paclitaxel chemotherapy. But we have 3 different options for maintenance now. Bevacizumab, which is also called Avastin. PARP inhibitors, there are several different brands of PARP inhibitors, or the combination of the two. And I think in the interest of time, I'm not going to go over what these are so much, but they have different side effect profiles and different things about how you would feel. Same for the PARP inhibitors. PARP inhibitors specifically are particularly effective for cancers with BRCA1 or BRCA2 mutations, getting back to the genetics. So if you inherited a mutation or if it spontaneously arose in your tumor, PARP inhibitors work particularly well. Some cancers without those can also respond, but this is where I'm going to kind of explain how knowing this can be helpful for the treatment decisions you make. So we were really excited. There was a very large clinical trial where people with BRCA1 and 2 mutations, either inherited or spontaneous in the tumor, so germline or somatic, finished their chemotherapy and then did 2 years of an oral PARP inhibitor maintenance drug, and it significantly improved survival. In fact, we think some people were getting cures that weren't otherwise getting cured as well. And so that has made it really an imperative, besides worrying about family members or kind of other risk of, other cancers, we really must not miss these mutations because this can greatly impact treatment decisions and influence how your course might go. And so about 15% have an inherited BRCA1 or mutation. 5% will have a somatic or mutation that started in the tumor. And we don't want to miss any of these. So if you had germline testing and it was negative for any inherited mutations, you should ask your doctor if your tumor has been tested. Most of the time now people are doing both, but it's something to just double check and make sure that you had. If you happen to have only had tumor testing, you also should ask if you have had germline testing. Sometimes people will make the mistake that, well, if they test in the tumor and we know the mutation is in all the cells of the body, shouldn't I be covered? But the way they test is different. It can actually miss up to 5% of mutations. So it actually is important that you get both. So take-home point number 2 is that most patients with ovarian cancer should also have somatic or tumor testing. Now, there was a second trial that looked at everyone with ovarian cancer, not just mutation carriers, BRCA1 and 2. And we learned that also a PARP inhibitor drug called niraparib helped even with people without mutations, that it was effective for everyone. And so this is where, I was, people sometimes say, well, then does it even matter? Do I need genetic testing at all if everyone should be getting this drug as maintenance? But the issue is that it is actually that benefit that I was sharing with you. The magnitude of benefit can be much more with a germline or somatic mutation or another special test I'm going to tell you about in a second compared to someone who doesn't have any of those things. So I would argue that you deserve to know that and that that's part of the discussion. Or you might decide everyone goes on it, but then if you're having side effects, you might interpret whether they're worth it or not in different contexts, knowing about the potential for benefit. And so So this is just kind of what I said. So people without BRCA1 and 2 mutations can benefit from PARP inhibitors, but it's harder to predict and the benefit may be less. But again, doesn't mean some people don't benefit. We absolutely have patients that do. And so there's one more test that we send to kind of help figure this out with our patients, which is called HRD, or homologous recombination deficiency, because tumors with that are also more likely to respond to PARP inhibitors. And so don't get too worried about this. You can just remember the term HRD. But again, I showed you that complex pathway of DNA repair. That's what homologous recombination is. It's a way to repair DNA. And so some of the things that cause homologous recombination deficiency are those mutations in BRCA1 and 2, but it's also in other genes and some non-mutation causes. And so we have a test for this that you can test your tumor. And it's called an HRD assay. It's imperfect, but it is there and something that you can test. And so we know that when they look kind of according to people who have BRCA mutations on the left, people who did not have BRCA mutations but had HRD, that homologous recombination deficiency, they had the most benefit with PARP inhibitors. But even with people who still didn't have any of those things, the HRD was negative or HR proficient, there was still a benefit, but it was less. So looking at a maintenance therapy, if someone has a germline or somatic BRCA1 or 2 mutation, we recommend olaparib maintenance with or without bevacizumab. That's kind of a separate discussion outside of the scope of today. If you don't have a mutation, but you're HRD positive, then the other PARP inhibitor is FDA approved for that. And there's a large benefit in these cases. For people who have HRD negative tumors, you can still go on a PARP inhibitor, or you can talk about bevacizumab, or you can talk about not doing any, and it's a conversation with your doctor. So take home point number 3 is patients with ovarian cancer who do not have germline or somatic mutations in BRCA1 or 2 could have the HRD test to help further stratify. All right, last thing that I'll talk about is that genetic testing can influence possible identification of novel therapies. And so this is kind of the exciting thing about personalized cancer therapy, is this idea that we can test people for different mutations or altered biologic pathways and say, if you have this one, you should get this drug. If you have this one, you should get this drug. And we're still working on getting there, but we're getting closer and know that we have some of those things. And so, there are all these biological pathways that if you learn that one of them is altered through tumor testing, can suggest maybe there's a specific cancer drug that could go with that. So that sometimes we don't always find those changes when you get the tumor testing, but if you have one of those, sometimes it can influence treatment recommendations. There's also something called testing for microsatellite instability or tumor mutational burden, and that can be used to be a predictor about whether or not immunotherapy could be considered. Immunotherapy isn't used a lot for ovarian cancer as much as some other gynecologic cancers, but it can be sometimes useful, especially if you have one of these things. And then the last molecular testing aspect I'll talk about is FOLR1 testing. So this is where they can take your, slides from your original surgery or from a biopsy and stain them. And if you have a high expression of this one folate receptor, then it can predict a response to a specific drug called mirvetuximab or Elahere. And so that is something that if you have had kind of more standard treatments for your ovarian cancer initially that haven't worked, that might be considered. So last thing is people ask, well, when should I get this testing done? So germline and somatic testing, because it kind of can influence upfront therapy, really people will usually do right at the beginning in the HRD. People ask me, well, what about if my cancer comes back? Should I get it tested again? And sometimes you can find new mutations, but a lot of the time they're similar. But I would say let's say you had a BRCA1 mutation, initially germline, so you didn't get tumor testing, so we didn't need it to guide initial treatment. Later, you might then choose to get tumor testing to see, well, what if there are other mutations that might guide therapy? And then the FOLR1 testing that I was sharing definitely can be useful for later. And so the ideal genetic testing I consider for ovarian cancer is the germline testing with a panel of all known ovarian cancer genes, somatic tumor testing, especially if the germline testing was negative, and then the other molecular testing, HRD, MSI tumor mutational burden, and FOLR1. And with that, I hope it was not too confusing, but I'll be happy to take questions. And thank you.